Good morning from San Diego. This is Dr. Rutledge, and I'm happy to announce a new podcast, Do Better to Be Better. It's not complicated. What we're saying is that we're going to be talking about those things that can happen in your life to make it better. Some are little things, eating better, making better choices, getting sleep. Things like that are very simple, but we think can make major impacts on all of our lives. We're excited to talk about it because we're involved in the daily practice of medicine and surgery for people who are overweight or suffering other metabolic disease. I'm happy to be allying with Dr. Illan here in Tijuana, Mexico. And we also have a new office in San Diego, California, and a future office in Mission Viejo, California. This is the beginning of our new podcast. Stick around. I think you'll have a good time. Good morning. This is Dr. Rutledge on the new podcast from Dr. Illan and myself here in Tijuana, Mexico, and San Diego, California. And today we're going to talk about a variety of things. It's an introduction. We may have 3 or 4 components of this introductory podcast, but we're going to start off with saying something really simple, that weight loss surgery is a major decision. And that's what we're going to talk about today. Bariatric surgery can change your life, but as they say in an old TV show, let's be careful out there. So it's important, and we want to go through some of those things today and provide you with information as well as opportunities to learn more about weight loss surgery, particularly here in Tijuana with Dr. Illan and myself, and where you can get more information on Facebook or other areas. So we'll get started and say there's good and bad in the area of weight loss surgery. The original technique of the mini gastric bypass that I created many years ago was one of the operations that for 20 years was viewed with mixed feelings. And what we know now is that it's growing around the world, and we're excited about that. And we're going to talk a little bit about that today. I'm also going to tell you that you can get in touch with me anytime by emailing me, and my email address is really short and simple. It's drr, that's Dr. R, at clos.net. In addition, I'm available on Facebook, and we have several thousand patients that are available to talk with you about their experiences, and they're probably more valuable than talking with me. My background, I've done over 6,000 mini gastric bypass patients over now up to 23 years out. The average operating time was only 36 minutes. The median hospital stay is 1 day in the hospital. And now you can go online and actually talk to people who are more than 15 or 20 years from their original surgery. That's an opportunity on Facebook, and we recommend that. There have been controlled prospective trials that have shown that the MGB is more than 2 times better than the sleeve. And in addition, it's reversible and revisable in less than 30 minutes. So for all those reasons, I think it's really exciting. If those of you who are watching on video, I have a slide here that shows the stars from all the people that have come to have surgery with me across the United States. And it shows basically that we cover the USA, and I'm happy to say from countries around the world now too. So I point this out because I don't think there are many other surgeons on earth that have comparable results for 20 plus years. And again, I encourage you to contact patients to talk about that. Here's just a couple of what I call fan mail comments from patients of mine that are more than 5 or 10 years out. So for example, hello Dr. Rutledge, my name is Angel T. I had the MGB with you back in February 2001. I can't believe it's been 20 years. My surgery weight was 300 pounds and I lost 150 pounds. I've maintained my weight loss and I have never been happier. Thank you so much for this amazing gift. Again, I just want to say how thankful I am for you and the MGB. My life has been changed forever. And although I could go on reading these for the rest of the day, I just have a few more. This is one from another surgeon. It's another patient. Hi, Dr. R. I'm now 75 years young and still loving my May 23rd, 2002 MGB. I'm 18 years post-op. I talked to Tricia this morning and you're this evening. Just wanted to check in and let you know I love you and your whole staff. You saved my life. If you remember, I was 276 pounds when I came for my mini gastric bypass. I've been doing well, and I'm still driving my motor coach bus across the country for a job at 75. I can still do the work of 5 men and outdrive them too, all thanks to getting that weight off. I went down to a size 2 over the last 20 years and gained up to a size 8. Healthy, happy, and loving every minute. Wanted you to know. Here's another one 20 years after her MGB. I had the MGB by Dr. Rutledge in 11/1/2000, just over 20 years ago. I weighed 252 pounds and am now 71. I've never had any issues with the surgery. My blood sugar dropped to normal range right after the surgery. One more, I had an MGB in 2003. I weighed 328. I'm now 124. I'm 60 years old, and I'll never regret having it done. He is truly caring. Thanks, Dr. Rutledge, for giving me my life back. Another one 11 years ago, and I'll stop there. On the other hand, there are Facebook groups, in addition to the MGB group, where people have not done so well. And one I'd recommend you might want to consider, there's a Facebook group called Weight Loss Surgery Ruined My Life. There, unfortunately, you'll find patients who've had difficulties, and as far as I know, there are not many who've had MGBs. In addition, you're welcome to keep up with me on a daily basis. I put information about health and well-being on the Facebook site, so you're welcome to follow me on Facebook, and I have some links in the audio and visual components of this that you can add in and follow me. So what can we say about the MGB? Well, it's tailored to fit the patient and the surgeon. We have very high levels of patient satisfaction. General surgery data and controlled data shows the MGB is as good as and sometimes twice as effective as the sleeve in treating diabetes. And there's resolution of diabetes in up to 85 or 90% of patients. You have a decrease in hunger, cholesterol, blood pressure, and inflammatory measures like C-reactive protein. Plus, it enforces a relatively healthy Mediterranean-type diet. On the other hand, there are surgeons who have reported difficulties and problems with the MGB, and this is what I call the MGB paradox. There are surgeons who've had difficulty and poor outcomes with the MGB, including bad weight loss, excess weight loss, bile reflux, even leaks and death. And I'm going to talk a little bit about that important component of your choice for what kind of surgery you have and who you have do your surgery. The following are just my opinions, but remember, I'm the one who created the MGB. I have patients more than 20 years out after the MGB, and you can talk directly to them to confirm some of these things. But again, I would emphasize, I've traveled the world, I've taught many surgeons to do the MGB, and so I have a reasonably good background to comment. On the video portion, you can see the countries I visited, and I couldn't get Australia on the map, but pretty much all of Europe, most of the United States, and the Middle East, India, Pakistan, and other countries have had me visit to talk about the MGB. For those of you who are new, the MGB is basically a pretty standard general surgical procedure. It includes a removal of the bottom part of the stomach and then a connection from the stomach to the small intestine. What these are called in general surgery is a callus gastroplasty and an anticolic Billroth II loop gastrojejunostomy. Since those terms were relatively complicated when I first started doing it, I abbreviated it and called the operation a mini, because it was minimally invasive at the time, a mini gastric bypass. The advantages of the surgery are it's simple, it's rapid and has a rapid recovery, it's elegant in many ways because it's less damaging to the human tissue, it's elegant, effective, durable now for over 20 years, powerful, it can be tailored to the super obese patient or to the thinner patient, and it's easily reversible and revisable. The early criticisms when I first doing it by the American bariatric surgeons, they said I was doing it too fast. They said I couldn't do it well if I did it so quickly. They said the hospital stay was too short, it was dangerous. They said I didn't take out the gallbladder, it didn't do it behind the colon, and they said it would all the patients would have crippling bile reflux and get cancer. In addition, they said the pouch was too big and the patients wouldn't lose weight, and they criticized me back 23 years ago because I used something called email and I had a website. So it turns out that the critics were wrong, and in all of those areas, now surgeons doing bariatric surgery are following my lead in not taking out the gallbladder, short operating times, short hospital stay, and a variety of other areas where it turned out that over 23 years ago and since then, I've been right. So, but we have faced criticism. The good news is all around the world, the MGB is being adopted with good outcomes. MGB surgeons have been unified, publishing, and now the International Foundation of Surgery for Obesity has demonstrated that they believe this is a recognized procedure and no longer experimental. But what now comes next? Well, with the explosive growth of the MGB, there have been some problems. That is, some surgeons are adopting it without adequate training, in my opinion. And with that, we've seen some complications. So we're excited about its growth, but we're also concerned that it be done safely. So for example, what we have worried about is that some surgeons adopting it may not understand all of the details in performing the operation. So that's one of the things we're going to talk about in this podcast series, how to have the operation done safely, and then how to prepare for it and how to manage it after surgery. The complications that we've seen around the world include things like a short pouch, a twisted pouch, what's called a bird's beak pouch, a narrow pouch, a stricture, and a variety of other major problems that lead to poor outcomes. We think there's an important need for safety when you have this kind of major operation, and so we're going to have some comments on that in the presentation. And I'm reminded of a recent famous statement which says, with great power comes great responsibility. Anybody can do a single anastomosis, but it doesn't always turn out well. So for example, in a French series, almost a quarter of patients, or 1 out of 5, had a narrowing and a partial blockage at the connection. That's not the MGB, that's the surgeon. In another study from France, this one from Paris, almost 1 out of 5 again had to have their surgery revised, their MGB they called it, because they lost too much weight. Again, that's not the MGB done by Dr. Illan and myself. So there's a paradox. There's problems with many of the surgeons who report little training in preparation for their MGB, whereas other surgeons, including myself, Dr. Lee in Taiwan, Dr. Kular in India, and others in the United States, with good outcomes compared to poor outcomes in other reports, with up to 10% of patients needing subsequent surgery. So many people have asked my advice, and the main part of today's presentation is we're going to give you some tips and pointers what you might want to ask your surgeon before you have an MGB with them. So here's our list of questions for today, and then we'll finish up. Who's your surgeon? My experience and published series suggests that some surgeons, usually with small experiences, have reported high complications. So here is a list of questions we're going to recommend you might want to consider asking your surgeon. Ask how many patients he's done. And I'm going to say he, it should be he or she, but I keep saying through the rest of this, I'll just use the masculine pronoun if you don't mind. If they've done a small number, I'm not sure you want to be one of his learning cases. Ask if you can contact some of his first 20 to 100 patients. This is worth doing because if he declines that, it may be because the outcomes were not that good. If he says he has confidentiality, you can point out that many Facebook groups have dozens, hundreds, or even thousands of pre-op patients or post-op patients you can talk with. My bias is talk with them before you choose that surgeon. Also, I suggest to talk to 10 to 20 of his patients directly that are at least 5 or 10 years after surgery. In my case, you can talk to patients who are up to 20 years after surgery. But if he is a new surgeon, if he's doing MGB for the first time, it may not be my recommendation that you choose that surgeon to have your surgery. I recommend you ask for access to 2 or even more copies of his videos of him doing the surgery. We recently looked at a patient who was having surgery in Europe at a major city, and she asked if he could show her one of his videos, and he declined. We were able, though, to find one of his videos on YouTube, and it was quite bloody and traumatic, and we both decided that it might not be the best choice to go ahead with that surgeon. Ask if he can broadcast one of their surgeries if they haven't already done so. A live one will give you the opportunity to see his skills and his technique. You might want to ask who taught him to do the MGB. There are surgeons who just read a paragraph in a paper and think they're skilled at the surgery. My bias is that's maybe not somebody you'd like to choose. Ask if you can contact the surgeon who trained the patient, the surgeon. Ask how much a gut will be bypassed. Ask how he decides how much to bypass. All these are critically important in the health of the patient after surgery, and we recommend you ask about these things. Ask about how many of his patients have bile reflux and ask why they have their reflux. Ask if you can talk to the patients and see if they have bile reflux and what he did to treat them and how they're doing now. Ask what he chooses to do to treat and prevent bile reflux. Ask if he says surgery for bile reflux is the treatment, and if he does say that, my opinion is I might not choose him for my MGB. Ask if he will, quote, fix your hiatal hernia. Ask why and why not, and again, I have feelings about that. You can ask, how is it possible for an MGB patient to die of malnutrition? Ask, isn't malnutrition starving to death, and doesn't it take weeks or months? Ask, why won't you just undo an MGB? How could it possibly die from an MGB? I think he needs to know the answers to these questions and how to manage it. Ask what the difference is in an MGB done for the first time on a patient and an MGB done after a failed sleeve. And if you're a failed sleeve, you might want to ask to talk to 10 or 20 of his failed sleeves who've been revised to an MGB. You're not alone being a failed sleeve. It's not your fault. And a recent study showed up to a third of patients will regain their weight after the failed sleeve. Other questions are, do they favor the high-protein, high-fat, low-carb diet post-op? Ask if they recommend artificially sweetened drinks and foods. I don't recommend either of these. You might ask what kind of technical errors can occur at the time of surgery and how he intervenes to prevent them. You can ask what causes a marginal ulcer or bile reflux. You can ask what size stapler he uses for the connection and what's the diameter he shoots for in the gastrojejunostomy. You can ask if he has post-op x-rays that you can look at of his operations. More questions are, you can ask where does he start the pouch when he creates it in the stomach. Ask when the biliopancreatic limb length is for patients who are 200 pounds or 300 or 400 pounds. In my opinion, the biliopancreatic limb length should be different. You can ask if it's important to dissect the EG junction. Ask if the anesthesiologist uses succinylcholine. You can ask what the mean length of stay for his patients are after his operation. And you can ask and call the head nurse of his hospital to just check. Anyways, this is a long opening presentation. Our goal here is to talk to you a little bit about preparing for your operation and questions. We have a lot more to talk about, a lot more details, but for those of you just starting your process of interest in the bariatric surgery of the mini gastric bypass, those are some questions that other patients have told me they found useful and valuable. So I'll go ahead and stop there, invite you to look in on this podcast more in the future. We'll have some more introductory information and how to contact us when you get in touch with us and when you see this video and listen online. Thanks a lot for visiting with us, and we'll talk to you again soon. Okay, thanks again for listening to our show today. This podcast, Do Better to Be Better, is going to be focusing on things you can do in your lives, your daily life, to make it better. We ask you to go ahead and subscribe at Apple Podcasts, Spotify, or YouTube so that you can keep up to date on our upcoming podcast series. In addition, we'll be on all of our social media channels. You'll be able to follow us, and right now you can follow me, Dr. Robert Rutledge, on Dr. R. Rutledge on Facebook, and there are thousands of people following us on that area, so you can find out more of what happens in their lives as they try to make their lives better day to day. Thanks again. Have a great day.